Welcome to Smart Talk. I'm Nell McCormack-Abom. February is the month for love and a great time to show some affection to your heart. Simple changes in your lifestyle can help keep your heart pumping strong for many, many years. Well, joining us now in the Greenwald studio at WITF's Public Media Center to discuss all things heart-related and to answer your questions are Dr. Steven Steinhubel, Director of Cardiovascular Wellness for Geisinger Health System, Dr. Mubashir Mumtaz, Chief of Cardiothoracic Surgery at Pinnacle Health, and a very familiar face to longtime viewers of WITF, Mike Greenwald, who underwent heart bypass surgery in January 2004. And I want to say welcome to all of you on this month of love and this month of heart awareness. It's a great time. Cardiovascular disease is America's #1 killer for both men and women. So critical information we can give you tonight. If you have a question, we really want to hear from you. We know you have heart and stroke related questions for the doctors. We've got two experts here. Give us a call, 1-800-729-7532, or you can email us at smarttalk@witf.org. Mike, I'm going to start with you. For many, many years you worked here at WITF, and back in October of 2003 you were actually at a PBS conference out in Denver. And what happened? What did you notice?
Well, I hope it was not my work at WITF all those years that prompted what happened in Denver.
I'm sure a little bit of the stress contributed.
I was, in fact, attending a conference, a PBS conference in Denver, an annual conference, and I was noticing as I was walking around town, doing some touring, walking up and down stairs, that I was experiencing shortness of breath, which I had not experienced before. And I actually put it down to the elevation, the Mile High City of Denver.
Chest pain.
I wasn't having chest pain. I was having just shortness of breath was the only symptom. And when I got home and I discovered that that same symptom was continuing, just walking up and down the steps at home, I realized, given my family history, that I better have it checked out. And sure enough, I had some tests done, and it turned out to be heart disease and blockages.
Well, two things. One, you said family history. What was the family history?
Well, my mother had bypass surgery when she was about 50, my father in his 70s, my brother when he was 57. I thought that I was going to escape it, because I hadn't had any symptoms. At the time I was, what was I, 62 years old, right?
62 years old. Yeah, it's hard to get that word out, wasn't it? That 62, that number. Well, there are two things he said, first of all, Dr. Steinhubel, that's really important. One, something wasn't right. He knew it wasn't right. He acted on it. The second thing, of course, family history.
Right.
What do you say about how Mike handled a question about his health?
Well, first, he was great to recognize that it didn't take the elephant on your chest kind of chest pain to make you think of something wrong and to get checked out. And that's often the problem, both with an acute heart attack or with what we call stable angina. That's the symptoms only when you're exerting yourself. And in about a third of patients, they won't have the classic chest pain. And one of the most common alternatives to that is shortness of breath with exertion, because your heart is not able to get all the blood it needs when you exert yourself, and then it can't pump as well. Your lungs will fill up with a little bit of fluid and you can't catch your breath. So it was very astute to be followed up.
For women, that's especially true. I understand a lot of time women misunderstand or don't react to the symptoms, because I think of my own mother. When she had her first heart attack, it was an upset stomach.
Right.
She felt sick to her stomach, and she just started taking, Alka-Seltzers. Well, it turned out she was having a heart attack.
Yeah.
Right. I think women are as much prone as men. In the past, we used to think that since men have higher risk of getting heart disease, that women are somehow safeguarded from this disease. But we've learned the last few years that this is #1 killer in women as well.
And is it the #1 killer for women? They experience more fatality because they don't present in those ways that you described, the elephant on the chest.
There are many reasons. Some of the reasons are that the symptoms could be atypical. You can end up having no chest pain, not only in women but also in diabetics. That is what we call silent heart attack. So one has to recognize that and realize that, and hopefully people know that for now, because it's been talked about everywhere in newspapers, media, websites, and also the fact that in women somehow it's a little bit more difficult to treat this problem because they have smaller arteries in the heart, and many other factors that could lead to a little bit more serious effects if the initial symptoms are missed in women.
Well, let's come back to you, Mike, and talk a little bit about, so you came back, you had the testing done, you found out that there was a problem, and then it became you needed to have surgery.
I did.
And back in 2004, what were the options here in
Well, I was prepared to have surgery here in the Harrisburg area, and I just coincidentally was having dinner with a friend who told me about a procedure that he knew about that was being performed at Lenox Hill Hospital in New York City by Dr. Subramanian there, who was, I gather, somewhat of a pioneer in minimally invasive surgery, which does not require the breast being opened and the arm or the leg being open.
You just didn't want to get into all that if you didn't have to.
Well, frankly, I hadn't really done all the research that I might have done, or I would have learned about this on my own. But I had the tip, and I acted on it. I went to New York, and it turns out I was a candidate for the surgery. And 2 months, October is when the diagnosis was made, and on January 8th, the surgery was performed.
Right.
In New York.
You've actually looked at the paperwork, Dr. Mumtaz, because this is what you do every day. You go in and actually you hold the human heart in your hand, which is pretty amazing when you think about it. But what he had done, why was it particularly effective and beneficial to him in the long run?
So obviously things worked out great for Mr. Greenwald because first of all he recognized his symptoms and he got medical help. He went to his doctor, so that's number one thing. Recently I treated a patient who had chest pain for 2 weeks. And unfortunately, despite heroic efforts, it's very difficult to fix those sort of problems. So he recognized that something was not right with him. He went to the physician who did further diagnostic testing, which included
is what on a treadmill, which was what uncovered the problem in the first place.
Talk about that real quickly. What is a stress test?
So stress test is maybe Dr. Hugo can
this is what you do first, because they come to you once the stress test shows this person needs to be operated on beyond what a cardiologist can do.
So when somebody has exertional symptoms, what we want to see is that exertional symptoms coming from the heart not getting enough blood. Really, when your heart doesn't get enough blood, 3 things happen, and the last of those 3 is chest pain or shortness of breath, or the symptoms. The first, what happens is the wall stops moving. So there are a couple ways we can take pictures, typically with ultrasounds. And then secondly, electrically it changes. And so when you do a stress test, most often we'll do an imaging study. So you'll walk on a regular treadmill like you'll see at any gym, but it goes a little bit higher and faster, typically every 3 minutes. And we want to see if you get symptoms. And if you're getting symptoms, we can look and see electrically, is there anything different in the heart? And then as you reach your maximum part, we'll take you off there and take pictures of your heart. And if your heart wall's not moving, then not only do we know that it is your heart not getting enough blood, but what part of your heart is not getting enough blood, how big of the heart is not getting enough blood. So it can tell you a lot of information that then can help guide us as to what we do next.
Well, give us an idea. You're a cardiologist, you're a heart surgeon. How do you decide who does what? There are interventions you can make that do not necessitate a full-blown surgery, although there are surgical elements of what you do. So kind of describe the difference, you two. I'll let you go to first, and then we'll go to Dr. Mumtaz.
I'll be the first to admit what I do is much easier than what the surgeons will do. So when you do a coronary angiogram, and we'll look at the actual blood vessels themselves to the heart, and it's just an X-ray, but when you take an X-ray of the heart, you can't see the blood vessels, you can't see any blockages, and so we'll thread a catheter up to the heart. Many people are used to it, and probably when you had your heart catheters from the top of the leg. Now we do it most frequently from the wrist, and so it's much more comfortable to the patients. It's you don't have to lay flat as long, but we still will thread it all the way up to the heart, put the catheter right at the openings of the blood vessels, and take pictures. If typically we see 1 or maybe 2 blockages, and then they're very discreet, we'll often choose to put in a stent, which looks a little bit like the spring at the end of a ballpoint pen, and it acts as a scaffolding, and so you thread that through a tight blockage in the blood vessel, you open it up, and that opens up the blood vessel. And sometimes the disease is too diffuse, sometimes they're completely blocked. Other reasons, if the heart is not pumping already from previous damage, not doing well, or even in patients with diabetics, are all things that make us think that maybe surgery is a better way to go to fix that.
And that's where you come in, and that's where Mike did, and they actually took the arteries, you said, from the chest right here. Right. There are 2 major arteries they could use.
I have to point out one thing in Mike's case, that his heart did not sustain much much damage. So his heart function was still good because he recognized the symptoms early. He went to the physician, he underwent the stress test, and subsequent to that he underwent a heart catheterization, which a person like Dr. Steinhubel would do. And then if there are too many blockages of the arteries are too calcified, they would send the person to me for heart bypass surgery. Heart bypass surgery has come a long way. It's not your grandfather's or your neighbor who's an 80-year-old surgery that was done 10, 15 years ago.
And you don't have to go to New York anymore for it.
You don't.
You can do it right here in Central PA.
You can come to our hospital in Central PA in Harrisburg, and we'll be happy to help you out with robotic heart surgery as well.
But that probably freaks some people out. I don't want, R2-D2 performing heart surgery on me. But you've said in some cases that's even better than the human hands on it. How do you measure that?
That is correct, because, the robot takes out the element of any error in the human hand, a tremor, or if it's a really fine anastomosis, a small vessel, it can help you get to that level with a magnified image. So the robot is not still commonly used for the actual anastomosis. Our technology has not gotten that far. But the robot is actually used to take these two arteries that run up and down in your chest on the either side of breastbone. These arteries, as shown by studies in the past from institutions like Cleveland Clinic, have shown that improve your survival in the long run rather than taking vein from your leg, which do not stay open too long for a period of time.
Right, Mike, you say you didn't know that until you
I didn't know that. I only knew that the arteries from the chest were used, but I didn't know that they had they provided more benefit in the long term.
That is true. So you actually had a great operation. These two arteries were used for 3 bypasses. One artery was used for 2 bypasses on the left side of the heart. And these days we can do it in a minimally invasive fashion where we can harvest these 2 arteries with the robot. The robot actually helps in taking these arteries down from the bones that it is attached to inside the chest. We take them down, and then we can make a small incision on the left side of the chest and spread the ribs rather than cut any bone.
That sounds a lot better.
And bypass the vessels.
We have a phone call right now from Robert, who's joining us from Hanover. Robert, we want to welcome you to Smart Talk. And what's your question or comment tonight?
Yeah, I'd like to ask, I have a heart murmur, and I'm a man of 79 years of age, and I wonder if there's anything you could ever do with a heart murmur. And the reason why I'm saying, am I more prone to a heart attack with the person who has a heart murmur than those who don't? And the other thing is, my heart murmur sometimes gets extremely loud. And sometimes when I lay in bed, I can hear the thing banging across my ear.
Well, Robert, I'll bet that is not a great way to go to sleep at night, is it?
No, it's not.
Well, thank you so much for calling. Who would like to take that? Dr. Mumtaz?
There are 3 sorts of diseases that we treat in the heart majorly. One is the coronary artery disease, which Mr. Greenwald had. That's called the blockage in the arteries of the heart. Then there is valvular heart disease, which some physicians specialize in. I specialize in heart valve repair and replacement treatment. And then there's heart rhythm disorders, which again, both cardiologists and some heart surgeons specialize in treating those by ablation. So what Robert is talking about, a heart murmur happens when the blood flows through the heart or flows through the valve of the heart, and the valve of the heart is either calcified or leaky. And when it causes that tightness, the blood kind of rushes through really fast through that valve. Or if it's causing leakage, the blood is going to try to flow in one direction, but the leakage is happening in the other direction. So the 2 streams of jet collide with each other. That forms a noise, which we call a murmur. And a physician can usually hear a murmur by listening to the patient's heart. Again, very important to go to your physician and have your heart checked out, once a year, or have a physical exam once a year, because these murmurs could be detected. You do not need a specialized test just to detect a murmur.
But if you're 79 years old, is it still a good time to deal with it?
Absolutely. It's never too late. Once you detect a murmur, you need specialized testing like echocardiogram that Dr. Steinhubel specializes in, and he can talk about that a little bit further.
Yeah. So, Robert, definitely there are many things that can be done.